They say you never know what you have until it's gone. I knew exactly what they had. I also knew they wouldn't realize it until much later. My name is Caroline Reese, and for 11 years, I was the Director of Clinical Operations at Riverside Memorial Hospital, a 400-bed teaching facility serving 3 counties in rural Pennsylvania. I didn't perform surgeries or diagnose patients, but I kept the machinery of healthcare running so smoothly that physicians could focus on medicine instead of logistics. The termination meeting happened on a Tuesday morning in March. I sat across from Dr. Marcus Chun, the newly appointed Chief Operating Officer, and Patricia Valdez from Human Resources. Marcus had been with Riverside for exactly 4 months, brought in from a consulting firm in Boston with promises of operational efficiency and cost reduction. Caroline, we've decided to restructure clinical operations, Marcus said, adjusting his tablet on the conference table. The new model will distribute your responsibilities across existing department heads. It's more aligned with contemporary hospital management practices. He slid a severance packet across the table. 3 months' salary, continuation of health benefits through the end of the year, accrued vacation time. We appreciate everything you've done for Riverside, Patricia added. This isn't a reflection on your performance. It's simply an organizational evolution. I read through the documents carefully. Everything was in order. When would you like me to leave? Marcus seemed surprised by the question. We were hoping you could stay through the end of the month. Help with the transition, document your processes. I can stay through Friday, I said. That should give me time to organize my files. They exchanged glances. We were thinking a longer transition period would be beneficial. Friday works better for me. Marcus cleared his throat. Well, we'd appreciate any documentation you can provide. Your institutional knowledge is valuable. I nodded and stood. We shook hands. I left the conference room and walked directly to my office on the 3rd floor. The thing about hospital operations is that they're invisible when they work correctly. Nobody notices the intricate scheduling that ensures surgical suites are cleaned and prepped between cases with exactly the right equipment. Nobody thinks about the supply chain choreography that keeps critical medications stocked without tying up capital in excess inventory. Nobody appreciates the vendor relationships that guarantee rapid response when equipment fails at 2 in the morning. I'd built these systems incrementally over 11 years, starting when Riverside was a struggling community hospital losing money and patients to larger facilities in Pittsburgh and Philadelphia. When I'd arrived, the hospital was running 8 operating rooms with paper scheduling systems. Surgeons would double book rooms, creating chaos and cancellations. The supply closets were either overstuffed with expired materials or desperately short of essentials. Equipment breakdowns could shut down entire departments for days, while administrators haggled with service contractors. The previous operations director had left abruptly after a particularly brutal board meeting where trustees had questioned why the hospital was hemorrhaging cash despite full patient capacity. They'd hired me from a smaller hospital in Ohio, where I'd successfully turned around similar operational problems. My first 6 months at Riverside, I'd simply watched and documented. I'd shadowed nurses during shift changes, observed surgeons in the OR, sat with supply staff during inventory counts, attended maintenance calls at odd hours. I'd asked questions and taken notes. Then I'd started making small changes. A new surgical scheduling protocol that accounted for procedure complexity and cleanup time. A just-in-time inventory system for high-cost supplies. Service contracts renegotiated with performance guarantees and penalty clauses. Within 2 years, surgical cancellations had dropped by 73%. Equipment downtime had decreased by 61%. Supply costs had fallen by $1.2 million annually without compromising patient care. By year 5, we'd added 4 new operating rooms and expanded the cardiac unit. By year 8, Riverside had become a regional referral center for complex surgeries. Physicians recruited from prestigious programs specifically cited our operational efficiency as a factor in their decision to join our staff. I'd built these systems through relationships, knowing which vendors could deliver emergency supplies within hours, understanding which service technicians actually knew how to repair aging equipment, recognizing which nurses had the experience to train others in new protocols. I'd also built them through documentation, but the kind that mattered. Not formal policy manuals that nobody read, but working knowledge embedded in spreadsheets, email threads, vendor contacts, and informal networks. The kind of information that couldn't be transferred in a week or even a month. Dr. Marcus Chun had arrived in November with an Ivy League MBA and a resume filled with healthcare consulting projects. He'd spent his first 2 months attending meetings, reviewing reports, and asking questions that revealed he understood healthcare administration in theory, but not in practice. During our first one-on-one meeting, he'd asked me to explain my role. I manage clinical operations, I'd said. Right. But specifically, what does that entail day to day? I'd pulled up my calendar and walked him through a typical week. Coordination meetings with surgical department heads, vendor negotiations for equipment service contracts, supply chain reviews, crisis management when unexpected problems emerged. He'd nodded along but seemed underwhelmed. These seemed like tasks that could be distributed across existing managers. Most hospitals don't have a standalone clinical operations role at your level. Most hospitals also don't maintain our surgical volumes with our facility size, I'd replied. The efficiency comes from centralized coordination. Perhaps. I'd like to review your budget allocation over the next few weeks. That conversation had set the tone. Marcus had come to Riverside believing he could apply generic management principles to specific institutional challenges. He saw my salary as an expense that could be eliminated, not as infrastructure that enabled revenue. The board, facing pressure from declining Medicare reimbursements and increasing competition, had been receptive to his cost-cutting proposals. My position, with its substantial salary and benefits, was an obvious target. What Marcus didn't understand was that my value wasn't just in the work I did, but in preventing the work that would overwhelm everyone else in my absence. On Friday afternoon, I packed my office. 11 years fit into 3 cardboard boxes: awards, photos, a few books, personal items. The real archive was in my filing cabinets and computer, and I made no special effort to organize it beyond my usual standards. Dr. Sarah Kim, the chief of surgery, stopped by as I was packing. "Caroline, this is insane. You know that, right?" "It's a business decision," I said, continuing to sort papers. "It's a stupid business decision. Who's going to manage surgical scheduling? Who's going to handle vendor contracts when they come up for renewal? Marcus says those responsibilities will be distributed." Sarah laughed bitterly. "Distributed to whom? I'm a surgeon, not an operations manager. I barely have time to review my own cases, let alone coordinate the entire surgical department. I'm sure you'll figure it out." She was quiet for a moment. "You're not even going to fight this? What would be the point?" "The point is that this hospital needs you. We all know it, even if Marcus is too stubborn to see it." I looked up from my packing. "Sarah, I've spent 11 years making things work here. If the administration believes that work isn't valuable enough to maintain, then maybe they need to learn why it mattered." She studied my face. "You know something? I know what I built. That's all." My husband Daniel was waiting when I got home. He'd taken the afternoon off from his architecture firm. "How did it go?" he asked. "Smoothly. Everything's done." He pulled me into a hug. "I'm sorry. I know how much that place meant to you." "It's fine. Really. What will you do now?" I set my boxes down in the home office. "Take a few weeks off. Update my resume. Something will come up." What I didn't tell him was that I'd already been contacted by 3 other hospital systems in the region. My reputation in Pennsylvania healthcare circles was solid, and word of my departure from Riverside had spread quickly. I also didn't tell him that I expected my phone to start ringing within 2 weeks. The first crisis hit on Monday morning, 6 days after my departure. Dr. Chen called at 8:47 a.m. I was on my second cup of coffee, reading on the back deck, and I let it go to voicemail. "Caroline, Marcus Chen here. We're having some difficulty accessing the surgical scheduling database. The login credentials don't seem to be working properly. Could you give me a call back when you have a moment?" I deleted the message and went back to my book. 3 more calls came throughout the day. By evening, Sarah Kim had texted me. "System is completely down. Surgery's being rescheduled. It's chaos. Are you okay?" I replied, "I'm fine. Thanks for checking in." The surgical scheduling system was custom software I'd implemented 6 years earlier, built by a small development firm in Harrisburg. I'd worked closely with their lead programmer to create something tailored specifically to Riverside's workflow. The system was maintained through a service contract that required annual renewal and regular security updates. That contract had expired 3 weeks before my termination. I'd sent Marcus 2 reminder emails about the renewal, which required his approval as COO. He'd replied that he was reviewing all vendor contracts and would get back to me. Without the active service contract, the system security protocols had automatically restricted access to prevent unauthorized use. The developers would need to reactivate the system, but that would require either renewing the contract or negotiating emergency service at a premium rate. More importantly, even with access restored, Nobody at Riverside knew how to use the advanced features that made the system valuable. I'd spent years training surgical coordinators on the specific protocols for different types of procedures, the contingency planning for emergencies, the optimization algorithms that maximized room utilization. Tuesday morning brought a call from Patricia Valdez. Caroline, I hope you're settling in well. I wanted to reach out about a consulting arrangement. Dr. Chin mentioned there are some ongoing projects that could benefit from your expertise. We'd be happy to discuss an hourly rate. I was at the grocery store when she called. I let her finish her voicemail before continuing my shopping. By Wednesday, the calls had intensified. Marcus left 2 voicemails and sent 3 emails. The tone shifted from casual requests for assistance to increasingly urgent pleas for help with what he termed unforeseen technical difficulties. Sarah texted again, lost a surgery today. Wrong equipment prepped. Patient had to be rescheduled. Marcus is panicking. The equipment issue didn't surprise me. The surgical supply system I'd implemented tracked instrument sterilization cycles, maintenance schedules, and specific requirements for different procedures. I'd trained the central supply staff on protocols for complex cases, but those protocols were built on years of institutional knowledge about surgeon preferences, backup equipment locations, and vendor response times for emergency orders. Without that coordination, it was inevitable that staff would fall back on general procedures that worked for routine cases, but failed for specialized surgeries. On Thursday, I received a call from Dr. Elizabeth Morrison, the hospital's chief medical officer and my former ally on the executive team. Unlike the others, I answered. Caroline, I'm not going to pretend this is a social call. We need your help. Hello, Elizabeth. How are things? Honestly, falling apart. The surgical schedule is a disaster. We've had 2 cases canceled due to equipment problems. The supply department is ordering random items because nobody knows what we actually need. And Marcus just discovered that half our equipment service contracts are coming up for renewal, and he has no idea how to negotiate them. That sounds difficult. Caroline, please. I know you didn't want to leave. I argued against this decision. But right now, we have patients being affected. We need someone who knows how these systems work. I paused, considering my response. Elizabeth, I offered to help with the transition. Marcus said my documentation would be sufficient. Obviously, it's not. What would it take to bring you back as a consultant? Name your price. I appreciate the offer, but I've already accepted a position elsewhere. Silence on the line. You've what? I start as Vice President of Operations at Millcrest Regional next Monday. The contract was finalized yesterday. Millcrest Regional was Riverside's primary competitor, a larger hospital system 40 miles west with better facilities and more resources. They'd been trying to recruit me for 2 years. When word of my termination reached their CEO, she'd called within hours. Caroline, Millcrest is our direct competitor. If you go there, then you'll compete with me instead of employing me. That was the choice your administration made. Please, just give us a few weeks. Help stabilize things. We'll discuss a permanent position, whatever you want. I'm sorry, Elizabeth. I've made a commitment. I ended the call feeling neither satisfaction nor regret. Just clarity about what came next. The emails from Marcus became increasingly desperate over the following week. He discovered that the vendor relationships I'd built weren't just contractual, they were personal. The service technicians who would respond to emergency calls at midnight didn't do so because of contract terms. They did it because I'd treated them with respect, understood their constraints, and ensured they were compensated fairly for urgent work. Without those relationships, Riverside was getting standard service at standard response times. When an MRI machine went down on a Saturday night, a machine critical for stroke diagnosis, the repair company quoted a Monday morning service call. In the past, I would have called the senior technician directly, explained the clinical urgency, and had someone on site within 2 hours. Now, patients were being transferred to other facilities, and Riverside was losing both revenue and reputation. Sarah texted me a week into the crisis. We're hemorrhaging patients. 3 surgeons are threatening to take their cases to Millcrest. Marcus is in meetings with the board daily. This is bad, Caroline. I didn't respond. The board meeting happened 2 weeks after my departure. I heard about it from Dr. Morrison, who called me that evening despite my clear indication that I wasn't available to help. They're talking about reversing your termination, offering you whatever compensation you want, giving you broader authority, apologizing publicly if that's what it takes. That's generous of them. Caroline, please. I know you're angry. I'm not angry, Elizabeth. I'm just no longer available. Is there anything we can do? Anything that would change your mind? I thought about the question carefully. No, I don't think there is. Can I ask why? Is it just about Millcrest's offer? It's about respect. Marcus made it clear that my work wasn't valued enough to justify my position. The board agreed. I'm not interested in working somewhere I have to prove my worth every budget cycle. She sighed. For what it's worth, Marcus is likely to be terminated. The board realizes he made a catastrophic error in judgment. That doesn't change my decision. My first day at Millcrest Regional was exactly 3 weeks after my termination from Riverside. The CEO, Dr. Jennifer Harding, gave me a tour of the facility and introduced me to the executive team. Caroline comes to us with an exceptional track record, she told the assembled directors. She built one of the most efficient surgical programs in the state at Riverside. Now she's going to help us do even better. The irony wasn't subtle. Several people in the room would have known about the situation at Riverside. My first assignment was to audit Millcrest's operational systems and propose improvements. As I reviewed their processes, I saw dozens of inefficiencies, the same issues I'd solved years earlier at Riverside, but which Millcrest had never addressed due to lack of focused expertise. Within a month, I'd submitted a comprehensive operations plan. Within 3 months, we'd implemented the first phase of changes. Surgical scheduling became more efficient. Supply costs dropped. Equipment uptime improved. And as I'd expected, physicians started noticing the difference. For months after joining Millcrest, I received an unexpected visitor. Dr. Sarah Kim asked to meet me for coffee at a cafe halfway between our 2 hospitals. I'm leaving Riverside, she said after we'd ordered. I wanted you to hear it from me first. Where are you going? Here, Millcrest. I've accepted a position as Director of Surgical Services. I wasn't entirely surprised. Sarah was an excellent surgeon with strong leadership skills, and she'd been frustrated with Riverside's administrative chaos long before my departure. They're falling apart, Caroline. After you left, it was like watching a building collapse in slow motion. The surgical volume has dropped 30%. 3 more senior physicians have left. The board fired Marcus last month, but the damage is done. Who replaced him? They brought in an interim COO from a consulting firm. She's competent enough, but she's trying to rebuild systems that took you years to create. It's not working. Sarah paused, stirring her coffee. There's something else. Riverside is exploring a potential merger with Millcrest. The board finally admitted they can't sustain operations independently. I processed this information carefully. A merger would make sense strategically. Millcrest had the capital and infrastructure. Riverside had the geographic coverage and existing patient relationships. Combined, they could dominate the regional healthcare market. Does Jennifer know you're telling me this? Sarah smiled slightly. She's the one who suggested I mention it. Said you want to know what's coming. The merger negotiations took 6 months. I wasn't directly involved. Those discussions happened at the board and CEO level, but I was asked to assess Riverside's operational systems as part of the due diligence process. Walking through Riverside's facilities felt strange. The hallways were familiar, but the atmosphere had changed. Staff looked stressed and uncertain. The surgical schedule board showed noticeable gaps. Supply rooms were disorganized. I met with the interim COO, a woman named Margaret Torres who'd been brought in to stabilize operations. I've read about your work here, she said as we toured the administrative offices. It's impressive what you built. I've been trying to recreate some of those systems, but frankly, I don't have the institutional knowledge. How are the vendor relationships? She grimaced. Terrible. We're paying premium rates for standard service. I've tried to rebuild the personal connections you had, but that takes time we don't have. In my report to Jennifer, I was honest. Riverside's operations were salvageable, but it would require significant investment and time. The physical infrastructure was solid, but the operational systems had degraded substantially. Staff morale was poor. Physician recruitment had stalled. I also noted that with proper leadership and resources, Riverside could be restored to its former efficiency within 18 months. Would you be willing to oversee that restoration? Jennifer asked after reviewing my report. As part of the merger? If it goes through, yes. We'd create a new role, Senior Vice President of Regional Operations, overseeing both facilities. You'd have full authority over clinical operations at both hospitals, budget autonomy, and direct reporting to me. It was a significant promotion from my previous role at Riverside, and even beyond my current position at Millcrest. What about the staff at Riverside? The people who are still there? Anyone competent stays. Anyone not meeting standards gets additional training or transitions out. Your call. I thought about the physicians and nurses and support staff I'd worked with for 11 years. Most of them hadn't wanted me gone. They'd been casualties, of an administrative decision they couldn't control. I'd want to bring in my own operations team. People I trust. Approved. The merger was finalized 8 months after my termination from Riverside. The new organization was called Millcrest Riverside Health System, with facilities spanning 5 counties. On my first day as Senior VP of Regional Operations, I arrived at Riverside's administrative offices. The building was the same, but the sign out front had changed. Jennifer and I held a joint meeting with Riverside's remaining staff. She introduced me and explained the operational integration plan. Many of you know Caroline from her previous work here. She built the systems that made this hospital successful, and she'll be leading our efforts to restore and improve those systems across both facilities. I spoke briefly about the transition plan, the timeline, the support available to staff. I emphasized that we were investing in people and infrastructure, not cutting costs at the expense of patient care. After the meeting, several former colleagues approached me. Some apologized for not speaking up during my termination. Others expressed relief that there was finally a clear operational direction. A few simply said they were glad I was back, even if the circumstances were different. Dr. Morrison found me in the afternoon. I suppose I should say I told you so. About what? That letting you go was a mistake. Though I'll admit, I didn't expect it to end quite like this. Neither did I. For what it's worth, I'm glad you're here. We need you. 18 months after the merger, Millcrest Riverside Health System had become the dominant healthcare provider in Western Pennsylvania. Surgical volumes had recovered and exceeded previous levels. Patient satisfaction scores had improved. Physician recruitment was strong. I'd rebuilt the operational systems at Riverside, but better than before. This time with redundancy, documentation, and distributed knowledge so that no single person's departure could create catastrophic failure. I'd also created a training program for operations managers, teaching the next generation of healthcare administrators not just what to do, but why it mattered. The program had attracted participants from hospitals across the state. On a Tuesday morning in September, exactly 2 years after my termination from Riverside, I sat in my office reviewing quarterly operational reports. Both facilities were exceeding performance targets. We'd just been approached by a third regional hospital interested in joining our system. Jennifer knocked on my open door. Got a minute? Of course. She sat down across from my desk. The board approved your proposal for the Center for Healthcare Operations Excellence. You'll have full autonomy to design the curriculum, hire faculty, and establish partnerships with regional hospitals. This had been my condition for staying after the integration was complete. Not another promotion or salary increase, but the creation of an educational center that would train healthcare operations professionals and share best practices across institutions. Thank you. This means a great deal. You've earned it. What you've built here, not just the operational systems, but the culture around them, it's exactly what healthcare needs. After she left, I looked out my window at the parking lot where I'd carried boxes to my car 2 years earlier. Everything had changed, yet somehow felt inevitable. I hadn't sought revenge against Riverside or Marcus Chun. I hadn't needed to. I'd simply moved forward, continuing to do the work I knew mattered, and let the results demonstrate what had been lost. Sometimes the best response to being undervalued isn't anger or retaliation. It's patience and competence. Build something better elsewhere, and let the contrast speak for itself. The systems we build outlast any single decision, any single administrator, any single moment of poor judgment. What matters is the work itself, and whether it serves the people who depend on it. I'd learned that lesson years ago when I first started building operational systems. Now I taught it to an organization that thought it could function without them. Some lessons can only be learned through absence. The weight of silence is heavier than any argument.